Hello, everyone. Welcome to this very exciting webinar on the relationship between hypertension and COVID-19. There have been a lot of very exciting novelties, but as you see, we will address what we know, but also we will address what is yet to be known, because there is still a number of uncertainties. So my name is Stéphane Laurent. I am Emeritus Professor of Pharmacology at Paris University. I am a former president of the European Society of Hypertension. And today I have the great honor to co-chair this session with Professor Giuseppe Mancia from Milano in Italy, and whom you know certainly, and who is, because he's one of the most famous scientists in hypertension. So the program will be in three parts. The first part will address the basic and evidence for the relationship between hypertension per se and COVID-19 that I will address. And then Professor Giuseppe Mancia will address the amount of clinical evidence and will focus on the three major paper published in New England Journal early May. And finally, we will have a 20-minute discussion. So, excuse me, let's start with this first part. My task today is to address what we know, what is yet to be known. This is my disclosure. And if you have a look at the Web of Science picture, you see that more than 14,000 papers have been published during the last months, which is absolutely never seen in science. If you focus on COVID plus hypertension, you have more than 200 papers. And now, if you focus on COVID plus ACE2, you have more than 300 papers. So ACE2 is at a cornerstone, as you will see, of the virus infection, and that the possibility that there is a relationship between hypertension and COVID-19. I will address two major issues. The first one is hypertension per se risk factor for susceptibility to COVID-19 infection and its complications? And in the second part, finally, is it true also for those treated with ACE inhibitors or ARB? Are they at increased risk for COVID-19 infection and its complications? So let's start with the first one. And you have been aware that during the first 3 months of this year, we had a huge number of statements in internet, TV, radio, newspaper, magazine, that finally there were 5 major risk factors for COVID-19 infection, complications, and ICU admissions. There were age, more than 65, male sex, hypertension, obesity, and diabetes. And the other one, COPD, heart disease, immunosuppressive therapy, were quoted less often. But the problem is, why is hypertension quoted as often as the other? Because from my point of view, from any pathophysiology, I do not see any true obvious link, and you will understand why. Is it by analogy with influenza and community-acquired pneumonia? But clearly, although hypertension is the most prevalent chronic condition in the elderly, it is not independently associated with pneumonia. And you will find a number of papers showing that. So the other possibility is that it is a true independent association, but then you should have, as an explanation, specific mechanism. And what are they? So everything started with this Chinese paper published in Nature Review Cardiology. We stated that SARS-CoV-2 infects the host cells through the ACE2 receptors, so leading to COVID disease, while also causing acute myocardial injury and damaging the cardiovascular system. So this paper called our attention on the damage of the whole cardiovascular system, good, but it focused also on the increased levels of ACE2 in response to RAS inhibitors. And because these are functional receptors, it evoked the possibility that finally hypertensive antihypertensive therapy with ACE inhibitors or ARB should be carefully considered, because it could lead to danger of safety and potential complications. And stated at the end that elderly people with comorbidities are more likely to be infected with SARS-CoV-2, especially those with hypertension, coronary heart disease, or diabetes. And why is it written with hypertension? In the meantime, but a little bit later, a very interesting paper published in The Lancet considered that it could be a kind of disease affecting the endothelial cell. They named it endothelitis, endothelial cell infection, because they found in the kidney with electron microscopy viral particles in endothelial cells of the glomerular capillary loop. Also, in the small arteries of the small bowel, they found the mononuclear cell infiltrates within the intima of the lumen of many of these vessels. Not only in the kidney and the bowel, but also in the lung. And here you see that in the thickened lung septa, including large artery, you have also mononuclear neutrophilic infiltrations. So is it everywhere endothelitis, all over the body, or is it clearly a lung disease? And a few weeks later, a beautiful review published in New England Journal of Medicine addressed these various hypotheses. They started first by stating that in the lung, the viral spike glycoprotein of the SARS-CoV-2 interacts with the ACE2, a cell surface enzyme. And interaction means potential factor in virus infectivity. Good. But because there is an ACE2 downregulation after viral entry, finally, ACE2 downregulation leading to less cleavage of angiotensin 2 into angiotensin 1,7 could lead to a higher availability of angiotensin 2. And finally, this is where you find hypertension, because in some form of hypertension, there is a higher availability of angiotensin 2, inducing acute lung injury, adverse myocardial remodeling, vasoconstriction, vascular permeability. So if there were mechanisms, specific mechanism explaining why hypertension per se could act as a risk factors, you could retain the first two given by the New England Journal of Medicine. First, downregulation of lung ACE2. Second, increased plasma concentration of angiotensin 2. And we know that it is a risk factor for acute respiratory distress syndrome. But there are other possibilities that you have probably read too. Reduced immunity in hypertensives, although confounding factor exists because this reduced immunity occurs also in dyslipidemia, in obesity, and metabolic syndrome. Hemodynamic factors also. There is an increased arterial stiffening that could aggravate the myocardial toxicity of the virus. What about the endothelial toxicity of the virus, impairing vasomotricity, having a prothrombotic effect and pulmonary embolism? And we knew that pulmonary embolism was a very frequent complication of those pneumonia. Everything could, all of that could explain an impaired renal and cerebral blood flow autoregulation. And finally, you may evoke the left ventricular hypertrophy linked to hypertension, aggravating the myocardial toxicity of SARS-CoV-2. So a number of possible mechanisms, unless, and there is another possibility, that hypertension is not a risk factor per se. And all these previously published observational data are confounded by age. So let's go back to early February in this JAMA paper, a small number of patients, 138, that you see here concerning the baseline characteristic of those patients infected, that the patient with hypertension were twice more frequent in those entering the intensive care unit compared to those not entering the intensive care unit. The problem is that you have a difference of age of 15 years between those in ICU and those in non-ICU. So clearly there is a confounding factor, which is age. Another paper from the Lombardy region by this Italian group split the data according to age. So what you see here is the percentage of patients who died in ICU according to whether they're hypertensive or not hypertensive, and according to their age decade, 51 to 60, 61 to 70. But what you see mainly is finally among those died in ICU, hypertensive were older than non-hypertensive, and no multivariate analysis has been done, so it is impossible to conclude. It's pure observation. So finally, we had to wait for the first multivariate analysis study to get the first evidences against the deleterious role of hypertension independently of age. And I will go to the first meta-regression analysis published in the Polish Archive of Medicine. So they listed a number of studies. They selected 13 papers, all from China at that period of the pandemic. And they confirmed the association between hypertension status and severity of COVID-19. Good. But when they did the meta-regression analysis relating the odd ratio of hypertension with severe form of COVID and the mean age of patients with severe COVID disease, finally, they showed that the association of hypertension was mediated by age. So clearly, you see that it is extremely difficult to find independent data. But I think that the most convincing data are those posted 15 days ago on the Open Safely platform. This is a platform that links the data, the electronic health records of patients with COVID-19, and a kind of notification system for death of hospital inpatients with confirmed COVID-19. So a huge number of patients, 17 millions, more than that, during the 3 months, February, March, and April. And you see more than 5,000 deaths attributed to COVID-19. But the beauty of the paper is that they used a multivariate Cox model. So at the end, what they show is that the age is the most important determinant. Male sex too, and obesity too. To a lesser degree, chronic respiratory disease, chronic cardiac disease, but hypertension not. Hypertension is not favoring cardiovascular, is not a cardiovascular risk factor, and certainly not independent, because when it is adjusted, it is no more significant. So I recommend you to read that review by the European Society of Hypertension Task Force, led by Reinhold Kreutz, who is the current president of the ESH. And they, in their conclusion, stated that available studies do not provide sound evidence that hypertension is an independent risk factor for lower respiratory tract infections and community-acquired pneumonia. They also stated that, however, they indicate that hypertension contributes to the increased occurrence of incident cardiovascular events in these patients, in agreement with the well-established risk associated with hypertension. So now let's discuss the second issue. If it is not hypertension per se and all hypertensive patients, are those treated with ACE inhibitors or ARBs at increased risk? And then again, during the last, I would say, 3 to 4 months, we had a huge amount of editorials, comments, letters favoring either the use of ACE inhibitors or ARB or contraindicating their use. I will not enter into the various pharmacological mechanisms, but clearly they were quite weak. So let's start again with this excellent review by Esch colleagues. They started with the main hypothesis. What is the main hypothesis? The main hypothesis is that when you give RAS inhibitors, you increase the ACE expression. If you increase the ACE2 expression, you may increase the virulence of the COVID pandemic. Okay. Now, are those treatments able to increase ACE2 expression or activity? Look at that list for ARBs. On the right, the increase or decrease or no change in ACE2 expression of activity. You see that mainly there is an increase. But these are animal data, many rats. There is only one study in human. If you consider ACE inhibitor, this is the same on the right column. You see that there is an increase, but again, very few studies in humans, only 3, and all others are in animals. But still, there may be a possibility. So one possibility would be in favor of the protecting role of ACE inhibitors and ARB, because RAS blockers, they reduce the plasma level of angiotensin 2, or they block the receptor. So in this square, red square of the figure, you see that finally, if you block this pro-oxidant, pro-inflammation, vasoconstriction, vascular leakage, pro-fibrosis effect of angiotensin 2, you will fight against lung injury, or at least the one that is induced by the virus entry. But in addition, by increasing ACE2 expression in the green cartouche, you see that there is also lung protection, antioxidant, anti-inflammation, vasodilation, anti-fibrosis. So very likely, this is much more protective effect than deleterious effect. And the conclusion of the working group was that the use of RAS blockers that inhibit the damaging effect of this RAS cascade in the lung appears reasonable rather than harmful. So now we need observational studies, and we need much larger studies. Still at the beginning, the first paper were published with a quite small number of patients. You see here in this Stein study published in JAMA Cardiology, the difference of percentage of patients taking ACE inhibitors or ARB in patients in group of severe COVID or non-severe COVID. And what you see is that patients with severe COVID were not more frequently treated with ACE inhibitors or ARB than those with non-severe, although they were older. And again, the confounding effect of age. So now we need clearly to go from small to large cohort, and it will be the talk of Professor Mancia, the study on top of the slide done in Lombardia, but also other studies in United States. And the 3 studies have been published in the May issue of the New England Journal of Medicine. And you will see that clearly there is no more doubt now. This is why the many learned society maintained their early statement, because you see that one was published in March the 12th, and it was the following: currently, there is no evidence that hypertension per se is associated with an increased risk of infection by COVID. Therefore, patients with hypertension should apply the same precautions as subjects in the same age category and with the same profile of comorbidities. And finally, in stable patients with COVID infection or at risk for COVID infections, treatment with ACE inhibitors or ARB should be executed according to the recommendation in the 2018 ESC-ESH guidelines. If you look at the New England Journal of Medicine paper, you see a number of scientific committee or organization issuing a statement which is very consistent with that of the European Society of Hypertension. To finish my talk, what remains to be known? I divided into 3 parts. First, I think that we need to learn a lot still on the cardiovascular pathophysiology of this virus infection. So what is the extent of endothelial damage? Is it a rare disease, or is it very frequent? And if it is frequent, is this a lung disease, or is it a disease of the whole body endothelial tree? Also, what are the mechanisms of this vicious circle between vascular endothelial cell dysfunction, the inflammation associated myocardial depression, the stress-induced cardiomyopathy, the direct viral infection of the heart and the vessel leading to heart failure, ischemia, and arrhythmia? We still do not know exactly, and what are the favoring factors. A second part is the pharmacology, but here it is a little bit disappointing because recombinant ACE2 clinical trials have been put forward in many reviews, and but when you look at the site of the clinicaltrials.gov, you see that the study that should have been done is Guangzhou in China has been withdrawn. It is done with a human recombinant ACE2. And there are only one which is one in an open label format using not a human but a bacterial recombinant ACE2. And finally, on the therapeutic side, is there any evidence from RCTs that ACE inhibitors or ARB can prevent complications? So I looked again at the clinicaltrials.gov website, and you see here only 2 papers, two studies, sorry, trying to demonstrate the prevention by ACE inhibitors of the complications, or at least infectivity complications. You see that there is one double-blind study with ramipril and one open label with captopril. There are more than that, 7 with ARBs, 6 of them using losartan, and half of them double-blind versus placebo, most in the United States. But still, between ACE inhibitors and ARB, there will be a number of data extremely interesting to follow. Regarding observational studies, there is much larger number, but their objective is not to show a protective effect of ACE inhibitors or ARB, but to show that discontinuing or reducing the dose of those drugs could have a favorable impact on the severity of COVID. But they are mainly retrospective and prospective observational data. So I doubt that they will give more evidence and that they will really be useful. It could serve to generate RCT hypothesis, but I doubt that they will close the debate. So, in conclusion of my talk, what we can conclude is that hypertension per se is not a risk factor for susceptibility to COVID infection and does not affect the outcome of those patients infected. There are no clinical data in humans to show that ACE inhibitors or ARB could either improve or worsen susceptibility to COVID infection, nor do they affect the outcome of those infected. Learned societies strongly recommend that the routine use of ACE inhibitors or ARB to treat raised blood pressure should continue and should not be influenced by concerns about COVID infection. And finally, discontinuing antihypertensive drugs, and more specifically ACE inhibitors and ARB, would result in much more harm than benefit in hypertensive patients. So thank you very much for your attention. And now I'm very happy to ask Professor Mancia to give his talk on the various large observational studies recently published in the New England Journal of Medicine. Thank you for your attention.
Good afternoon, ladies and gentlemen, distinguished colleagues. My name is Giuseppe Mancia. I'm Emeritus Professor of Medicine in the University of Milano Bicocca. And thank you very much, Stéphane, for introducing my talk, which is on the relationship between some types of antihypertensive treatment and the risk and severity of the COVID-19 infection. Now, Professor Laurent has already mentioned that a discovery done about 20 years ago, found that the COVID virus uses to enter the cell an enzyme, ACE2, which is one of the enzymes involved in the action of blockers of the renin-angiotensin system. Now, this has been found in abundance in several organs in animals and humans, the lungs, the heart, the kidney, the endothelium, and other organs. And this is one of the reasons why we now understand that the COVID-19 infection is not just a lung disease, but a systemic disease with a very strong cardiovascular component. It has also been found in the past few years that angiotensin receptor antagonists and ACE inhibitors overexpress ACE2 in animal and human organs. And this overexpression has been a matter of concern because, of course, increasing the keys to the virus entrance into the cell could increase the risk of getting the infection and even the severity of the infection. But there has been also an opposite hypothesis, that is that this indeed may have a protective effect, because ACE2 is not directly involved in the action of blockers of the renin-angiotensin system and the cardiovascular system, and it degrades angiotensin 2 to a vasodilator compound, and this degradation could somehow help stabilizing the cell membrane. And also we know that reducing angiotensin 2, which is a typical effect of ACE inhibitors, may reduce the angiotensin 2 dependent lung and organ injury. But these are both speculations. No evidence is available in men on one or another factor and which one, if anything, might prevail. But these hypotheses, speculative as they are, got into the scientific press and the lay press. And there's been a large echo all around the world about the possible consequences of this. You can read what was written in the Daily Mail a couple of months ago. People with high blood pressure and diabetes could be at higher risk of severe or fatal coronary virus symptoms because of how their medicines work, scientists say. And another statement more or less on the same issue. And because of this, we know that several people stopped taking ACE inhibitors or angiotensin receptor antagonists, which created a lot of concern because these drugs are probably the most commonly used drugs in the world, and they are first step and life-saving drugs in hypertension, heart failure, post-myocardial infarction state, chronic kidney disease. And we know that these life-saving drugs, if they are stopped, this is followed by a very marked increase in the risk of cardiovascular outcomes and mortality. Let me give you an example, but I could give you many other examples. This is data from the ADVANCE study, which is a study on more than 11,000 patients with type 2 diabetes. And antihypertensive treatment was strongly based on an ACE inhibitor, perindopril. And when we look at what happened in patients discontinuing this treatment during the study, compared to those continuing treatment, you can see that those discontinuing treatment had a major increase in diabetic-related micro and macrovascular complications, and even greater increase in the risk of mortality. So because of this, scientific societies in different countries and international scientific societies uniformly issued the recommendation not to stop ACE inhibitors or angiotensin receptor antagonist treatment because of the fear, the concern of being more susceptible to the COVID-19 infection, or having it in a more severe form. And of course, what was emphasized was that these are animal studies and animal-based hypotheses, and that there was no evidence of any kind of relationship between blockers of the renin-angiotensin system and the COVID-19 infection in men. This was a little bit ambiguous, however, because in a way, lack of evidence was equated to negative evidence. What really happened and was the situation is that this basic science-generated hypothesis remained untested in humans. Now, at the beginning of March, we thought that we could get some information on the relationship between blockers of the renin-angiotensin system and the risk of having the COVID infection from the Lombardy database. And you know that unfortunately Lombardy has been a region severely hit by the COVID pandemic. A very high number of people infected and a very high number of deaths, unfortunately. So what we did was to look at the names of the people infected in the regional COVID registry, which was organized by the health authority of the region very soon after the first information about the infection. Once we had these names, we went into another database of the region, which we have used in the past since many years to look at the data on adherence to cardiovascular treatments and therapeutic inertia for different cardiovascular types of treatment. The administrative database of the Lombardy region, which includes all residents in the region, about 11 million people. And there you have clinical information, past hospitalizations, co-treatments, and also any type of treatment the patient had for years and years, based on recording of each prescription in outpatients. So what we could do was to see which kind of treatment, antihypertensive treatment, and in particular, treatments based on the renin-angiotensin system blockers, patients were taking before having the infection. We added to the data analysis a control group precisely matched with cases for age, sex, municipality of residence, and this was done because in the region the infection was not uniformly distributed. Some places and provinces had a very high rate, other places almost no rate. But doing this, of course, we could match also for this factor. And the control group was 5 times as large as the number of infected people. Information was extended to previous hospitalizations 5 years back, and the chronic comorbidity score I will mention more in detail in a moment. And here you see the data we had. We collected data from more than 6,000 COVID-infected people and matched these data with more than 30,000 control. Age, identical in the two groups, was 68 years. 1/3 were women, and these were, of course, perfectly matched between the two groups. And you see what happened with the rate, with the use of ACE inhibitors and angiotensin receptor antagonists. They were more common in the COVID-infected people, which we call cases, compared to controls. And the difference was greater than 10%. 10% for ACE inhibitors, 13% for angiotensin receptor antagonists. But as you can see, this was the case for all other antihypertensive agents: calcium channel blockers, beta blockers, diuretics, including thiazide diuretics, loop diuretics, and anti-aldosterone agents. The difference indeed was sometimes larger than the difference shown by ACE inhibitors and angiotensin receptor antagonists. And this was the case also for several other drugs, non-cardiovascular drugs, which were included in the analysis. You can see, for example, that oral anti-diabetic drugs, they were more frequently used in cases, 25% more, insulin, 40% more, lipid-lowering drugs, 17% more, antiplatelet drugs, 27% more, oral anticoagulants drugs, 31% more. And drugs for respiratory diseases were used more frequently, immunosuppressant agents were used most frequently, and non-steroidal anti-inflammatory drugs were used more frequently. All drugs we included in the analysis had a greater use in patients infected than in controls. Now, what these data mean? Well, we thought that these data simply meant that people who get the infection, they have a background health poorer than control subjects. And this is reflected by their greater use of therapeutic drugs. And this has been confirmed by the other data of the study. Hospitalization for cardiovascular disease, respiratory disease, kidney disease, and neoplastic disease was always much more common in patients with the infection than in controls. And then we had the so-called chronic comorbidity score. Now, 3 years ago, we published a study in which we look at the ability to predict mortality by 34 items included in the database, which are weighted for their prognostic ability. And by having a score which included all these items, we could come up with a marker of the risk of mortality extremely sensitive for the Italian population. Data were collected in 2 million people, 500,000 in 4 different regions. One of them was Lombardy. And you can see that scoring the health state from 0 to 4, there was a progressive reduction in patient survival, very clear cut. And those scoring 4, well, they had a very high mortality rate over the next 6 or 7 years. And you can see here the distribution of these scores in our COVID-19 study. Score 0 and 1, that is the healthier conditions, well, this was more frequent in controls and less in infected people. But starting from score 2 to score 3 and 4, as you can see, the number of greater rate in COVID-19 infected people, the greater rate was, progressively more evident in infected people as compared to controls. Now, in a way, this is not new because now many studies have shown, and this is an element of knowledge which is going to remain with us, that there is no question that people having a background organ damage, having background cardiovascular diseases or pulmonary diseases of any other type of diseases, having cardiovascular risk factors, they have a greater risk of getting the infection as compared to people with less of these conditions. And this is data from a previous study, but I could show you many other data going exactly in the same direction. Now, when all these confounding variables were taken into account and the adjusted risk of getting the infection was calculated, as you can see, ACE inhibitors and angiotensin receptor antagonists didn't show any significant relationship with the risk of having the COVID-19 infections. And this was the case for calcium channel blockers, for beta blockers, and also for thiazide and thiazide-like diuretics, and also for anti-aldosterone agents. The loop diuretics, I'll come back to this at the end of my presentation. Now, one other point to analyze was what happened in people taking combination treatment, because combination treatment in Italy mainly involves, as a combination component, blockers of the renin-angiotensin system. But you can see that adjusted risk of having the COVID infection was not significantly different from controls, well, in patients using monotherapy, but also in patients under combination treatment. Now we had a very large database, so there was a chance of having important sub-analysis of the data. This was done in males versus females, in younger and older patients, in patients with the milder as compared to those with the critical or fatal infections. Critical meant patients in the intensive care units, and the data replicated precisely what was found in the group as a whole. So the final conclusion of this study was that there is a greater use of angiotensin receptor antagonists and ACE inhibitors in infected people, as well as of all antihypertensive agents and non-cardiovascular drugs. But this does not mean that these drugs modify the risk of having the COVID infection. It's just a reflection that individuals with a poorer background health are more prone to have the infection. And this, in our study, was confirmed by greater rate of hospitalization in the past 5 years and a worse chronic comorbidity score. So the conclusion is that no antihypertensive agents, in particular ACE inhibitors and angiotensin receptor antagonists, has any significant relationship with the risk of the severity of the COVID infections. And this is the case in different subgroups, younger and older patients, males and females, individuals with a mild infection and those with a more severe infection. Now, this was published less than a month ago in the New England Journal of Medicine, and in the same issue there were two other very large and very interesting studies going exactly in the same direction. One of them was the study by Reynolds, and you can see that what the authors found was that not only in all patients with the COVID infection, about 6,000, but also in the hypertensive fraction, and this was not available in our study because we didn't have blood pressure data to limit the analysis to hypertensive patients. But this was provided by the paper by Reynolds. It shows that use of ACE inhibitors or angiotensin receptor antagonists, but all other drugs as well, well, between people treated with these drugs versus those untreated with these drugs, there was no significant difference. And this was the case in all patients. And this is another analysis in the same study in which what was done was to look at whether use of antihypertensive drugs, blockers of the renin-angiotensin system in particular, made a difference in terms of severity of the infection in hypertensive patients and in all patients, in all the entire cohort of the study. And once again, you can see that there was no difference that justified a suggestion that blockers of the renin-angiotensin system could modify the severity of the infection. But I alluded to this before. We came across some drugs for which adjustment for confounding factors did not remove the relationship with the risk of infection. Loop diuretics, for example, they were much more frequently used in infected people compared to non-infected people. And this was accompanied, when adjustment was made, by a significant increase in the risk of infection in people using loop diuretics. This was the case also for insulin, antiplatelet drugs, anticoagulant drugs, immunosuppressants, and respiratory diseases. Now, there is no mechanistic reason why loop diuretics should be related to an increased risk of infection. We thought that more likely possibility was that our way of compensating or adjusting for the severity of the background health condition of the patient was not perfect. Loop diuretics were probably taken by old people with congestive heart failure, which was not completely removed by adjustment. And so it was not that loop diuretics facilitate the infection, but that they are a marker of a severe condition, possibly heart failure. But this is, of course, an interpretation of the data. And I think a further investigation on all these drugs could provide safer data on this special aspect. And this leads me to the second paper published in the New England Journal of Medicine, in addition to the paper by Reynolds and our paper. And this was a paper by Mehra, which compared large number of individuals with the COVID-19 infection surviving the infection with more than 500 people who died. Now you can see that, again, differences between use of different antihypertensive drugs was not significant between these two groups. Beta blockers, antiplatelet, insulin, other hypoglycemic agents as well, and angiotensin receptor antagonists as well. But two drugs were indeed, showed indeed a different use. Statin and ACE inhibitor. That is, the use of these drugs were greater in survival than in non-survivors, and the difference was statistically significant. Even the risk adjusted was statistically significant. Now, the number of individuals non-surviving taking ACE inhibitor was indeed very small. And this was probably the reason why a comment of the editors of the New England Journal of Medicine, there was an editorial accompanying these three papers, was that this was an unexpected result, and there was a good probability that this was due to unmeasured confounding. And this was not a reason for directing treatment in one direction or another during the COVID infection. So this is the conclusion which we could draw from the available data. Multiple evidence from large-scale observational studies is that ACE inhibitors and angiotensin receptor antagonists do not modify the risk of COVID-19 infection, nor do they modify the severity of the disease. And this is true also for other antihypertensive agents and also for non-cardiovascular drugs. But of course, there are some drugs for which residual risk remained after adjustment. We think that this is likely to be due to the background health condition, but further analysis and further data would be desirable. And this is in particular the case for use of ACE inhibitors and statin because of the data from one of these three large studies, as I mentioned before. Thank you very much for your attention. And now I had to go to the final 5 slides. Research is moving fast on COVID infection. There are papers, interesting papers published almost every day, which may contradict what was said before or amplify what was said before. One of them has been published just 2 or 3 days ago in The Lancet, and it deals with an issue which I touched at the end of my presentation. That is the possibility that indeed some drugs may be involved in the severity of the infection. And this is again a paper of Mehra, which I quoted at the end of my presentation, and showed that there was a significant relationship between use of ACE inhibitors and statin and survival of the patients with COVID-19 infection. The difference is at this time, the database was very large, almost 100,000 patients from different continents. And you can see that there were almost 15,000 patients with the COVID infections and more than 80,000 patients in the control group. The study was centered and focused on the possibility of a beneficial effect of chloroquine or hydroxychloroquine with the use of a macrolide or alone. Now, you can see first of all that this very huge database confirms in a way what I said before. And this, I think, is something on which we can now rely because many, many studies have shown that this is the case. That is that non-survivors have a poorer background, health background compared to survivors. You can see greater rate of coronary disease, heart failure, arrhythmias, diabetes, hypertension, dyslipidemias, respiratory disease, and so forth. Women are more protected from severity of the disease, and people with body mass index increased. They tend to have a worse outcome as compared to leaner people. As I mentioned before, the study was centered on the use of hydroxychloroquine or chloroquine, and the ability of these drugs to protect were analyzed according to many markers of protection from the disease, among which, for example, the length of the stay in the hospital, the need to go to mechanical ventilation, and so forth. And so the authors came up with a very comprehensive analysis of what could be the factors involved with the greater severity of the infection. And here, the surprise was, except for the fact that this is, of course, still an observational study, and so it doesn't have the reliability of randomized trials, but you can see that people who were under chloroquine, hydroxychloroquine, or with a combination treatment of chloroquine and a macrolide, well, they consistently showed greater mortality. I think the evidence that these drugs, which were supposed to have something antivirus in addition to an anti-inflammatory action, do not really protect the COVID-19 infected people, is becoming quite strong. But what I would like to show your attention to is that in this much larger database, because now people under ACE inhibitor who died were not just 16, as in the previous study, but almost 500. Well, you can see that this was confirmed. That is, people who were under ACE inhibitor or a statin had a significant protection against the severity of the disease. Some other factors also showed protection. For example, the Asian people, female, which is now very well known. So from this analysis, it would look like the story of the blockers of the renin-angiotensin system has not ended. There could be some development in terms not of what pre-treatment did, but what could be the advantages of continuing antihypertensive treatment based on blockers of the renin-angiotensin system, ACE inhibitor in particular, because this was not shared by the angiotensin receptor blocker, or lipid-lowering treatment by statin on the development of the disease. As I mentioned before, this is now based on more than 400 non-survivors which were under ACE inhibitor treatment. Those on statin, non-surviving the disease were more than 700 patients. So we are now coming up to rather large numbers. And I'm sure that future research will expand on these numbers and give us an even more clear idea of the situation. Thank you.
Very good. Hello, everybody. Thank you very much for joining us in a large amount. You were more than 600 attendees at this video conference and webinar. Thank you very much to Servier for organizing it. We have, I think, we have 10 minutes for questions. We saved a lot of questions, about 20, very interesting questions, but I tried to classify them into 4 or 5 groups. But clearly, the first group of questions was concerning the safety of prescribing ACE inhibitors or ARB in COVID patients. And so I had a question like, shall we stop ACE inhibitors in hypertensive patients who are on high risk of COVID? Other question like, should we initiate with a different antihypertensive in newly diagnosed patients? But clearly, that should have been clear now after this webinar. There is no reason to change anything from what has been stated by the guidelines, the European guidelines, the American guidelines, all possible guidelines concerning the treatment of hypertension. That should be clearly stated. Now, I have some question for Giuseppe related to the difference between the different protective effect or maybe the possible difference in deleterious and protective effect between ACE inhibitors and ARB. One question is about this issue. Is there any difference between ACE inhibitors and ARB regarding mortality? But you answered in one of your last slides. But there was another one, for instance, related to hypokalemia. Could it be a mechanism by which the ARB could be deleterious?
Well, can you hear me?
Yes, very well.
Okay. Well, it's a possibility. Another possibility, because you're talking, how the arguments are entirely speculative.
Yes.
Is that angiotensin 2 may have a damaging effect, and angiotensin 2 is reduced by ACE inhibitors, but it is increased by angiotensin receptor antagonists. And my first candidate would be this factor.
Yes.
Provided, of course, that future studies will confirm this. I think that you showed us a very, very informative slide, Stéphane, at the end, randomized clinical trials, which in the future will explore what continuation of treatment or randomization to continuing treatment or discontinuing treatment will do with ACE inhibitors and angiotensin receptor antagonists. I think this is the approach. More than observational studies, we should rely on what the future randomized trials will tell us about the protective effect.
I have also a question that states 6 days rule in those patients better if we hold them. I think that our colleagues would say if we stop or discontinue ACE inhibitors or ARB. In my opinion, it may be reasonable under frail hemodynamic conditions to hold them, of course. But would you retain that issue as an important one in 6 days?
Of course, hard to think that in 6 days there will be a rebound, but certainly stopping antihypertensive treatment in general during the infection may lead to an uncontrolled blood pressure rather quickly. I know that some people from the intensive care units, they tell that a number of patients with the COVID infection, they get an increase in blood pressure. I don't know if this happens because of stopping antihypertensive treatment. And we know, for example, if we can use analogical arguments, that an increased blood glucose is associated with a poor survival in these patients. So maybe the same is true for blood pressure, that we should not forget to keep blood pressure control during the infection in order to have a better outcome.
Yes, and I have another number of questions regarding the hyperactivation of the renin-angiotensin system, explaining the harmful effect of COVID on the cardiovascular system. I think that what we learn from that disease is the major role of renin-angiotensin system under acute and critical hemodynamic conditions. What do you think on the interaction between the virus, the RAS system, particularly in the elderly, regarding the study that you conducted and the MERA study published in the same issue of New England Journal of Medicine?
Well, again, I think that stopping these drugs, and having as a rebound maybe an activation of the renin-angiotensin system could be deleterious, and this deleterious effect, it may well be that it is more evidence in elderly people. And this could be one of the factors. Of course, we have a lot of possibilities around these hypotheses, but certainly the hypothesis that reducing the control of the renin-angiotensin system by stopping ACE inhibitors could be certainly a possible factor involved in the deterioration of the health in these patients. I mean, the infection is a long infection. It's not a 6-day infection in many people. It goes on for weeks and weeks. One of the reasons why we had a tremendous saturation of the intensive care units in Italy. We had about 5,000 beds in intensive care units, and they were saturated immediately, so people did not have an access to these units for weeks. Is that once these people were in the units, they stayed there for weeks and weeks and weeks. And so there is time, to me, for a deleterious effect of what we can call, I don't know if you agree, Stéphane, a mid to slow acting system like the renin-angiotensin system, not like the sympathetic system, which has a very immediate effect, but the renin-angiotensin system is slower. But I think considering that many patients have a long stay in the COVID infection, it can still have a deleterious effect.
Yes, we will finish in 2-3 minutes. There is a specific question regarding arterial stiffness, probably from somebody who knows that it is one of my favorite topics. The issue was pulse wave velocity used to stratify patients? I think it's a good question to the extent that the pulse wave velocity can reflect the acute inflammation. It would have certainly be interesting to measure it, but I am not aware of any study. I'm aware, by contrast, that the Artery Society is conducting a large follow-up study measuring arterial stiffness in those patients who survived to COVID. There is another issue regarding preeclamptic patient. Are they at higher risk of contracting COVID? Have you any data on that, Giuseppe?
I'm not aware of any data. Do you? I mean,
no.
But data are coming up every day, and even unexpected aspects of the disease. We are learning a lot every day. For example, the cutaneous manifestations of the disease, to me, they were unknown until 10 days ago, and then several papers came up. And this is now part of the phenotype of the COVID-19 infection, just to make an example. So we should have an open mind about this.
Last question, is aspirin safe in those patients with COVID? Regarding your study and the study by MERA.
Well, first of all, I think it doesn't do much, unfortunately. In Italy, what was advised at the very beginning of the infection, and this could have been a reason why many people went into irreversible damage, was don't take anything, stay home and take just aspirin. And I don't know whether it does harm rather than doing nothing. This I don't know. Maybe you have some more information.
No, unless sorry, I don't. Now I think that we are perfectly in time, and Giuseppe, I give you the chair to conclude our very exciting webinar.
Thank you very much.